Dr. Harris was a little delayed in the OR this morning. There he is. Perfect. Perfect timing. And that's what it's all about. It's all about the timing of things. But I'll go ahead and I'm going to introduce this next section. It's going to be the treating for acute venous patients. And the next doc I'd like to introduce is Dr. Lucas Ferrer. Lucas is a vascular surgeon from he's an assistant professor of Division of Vascular Surgery and Endovascular Therapy, University of Texas in Austin, and he is coming all the way from there to talk to us today about, let's see, his topic is advanced techniques and the treatment of DVT and pulmonary embolus. We're going to follow then with Dr. Harris's role of IVUS in the diagnosis of complex venous disease, and then his second talk, it's not just DVT anymore. So we're still in kind of the venous mode for the next section, and I'd like to introduce Dr. Lucas Ferrer.
Thank you, Chris, and thank you for the invitation. All right, so we're just going to talk a little bit about the data about treatment of DVTs and pulmonary embolisms and some visual illustrations of how we do it. So, not every DVT is the same. It's probably more of in some ways, it's more complex than arterial disease. You have to really take into account what the symptoms of the patients are, the anatomy, and the extent of the thrombus burden. Obviously, it's something that has gathered increasing awareness. We're seeing more and more of these patients. A lot of them have recurrent disease. These are patients that come back. About 1/3 of them have recurrent disease and can have lots of disabilities and increased mortality from their pathology. And here we see that the incidence of this problem is not going away. It's increasing, probably due to multiple factors. So these are kind of the triads that we've noted before in other studies. There's stasis, there's hypercoagulability, and endothelial damage. This is kind of the main pathologies behind the formation of this thrombus. So how do we treat it, and who needs inpatient therapy? The majority of the patients we treat, and now we're talking about DVTs, are patients that have iliofemoral DVTs that are symptomatic, or that have upper extremity, large kind of thrombus burden DVTs with symptoms. So how do we treat these patients in an endovascular fashion? So there have been 3 major studies. 2 of them noted that there were benefits in what we call post-thrombotic syndromes, these patients that have chronic venous claudication, venous hypertension, and associated symptoms. And 1 larger trial, the ATTRACT trial, which did not do a specific subgroup analysis to these patients, but it did not show that there was any benefit. But a lot of people question the results of that trial. So the peripheral endovascular interventions for DVTs are varied, multiple mechanisms based from catheter-directed thrombolysis, just a simple catheter injecting TPA, ultrasound-assisted thrombolysis, a catheter that vibrates while it injects TPA. You can do pharmacomechanical, which is basically catheters that inject TPA at the same time have jets that break up the clot and suck the clot. You can have different types of mechanical thrombectomy, from baskets to basically suction catheters, but their ultimate goal is the same, to basically reduce almost to its entirety the thrombus burden. The hard indications are phlegmaceous cerebral dolens, these patients that come with a very big extremity that is red to the touch and red and painful to the touch. IVC thrombosis, subacute and chronic iliofemoral DVTs with associated symptoms, and acute iliofemoral DVTs are also a subgroup of patients that can be treated. And here we have, a very young patient. This patient actually, and I've seen this association with testosterone replacement therapy. I've seen some patients with large thrombus. So he had a large iliofemoral DVT, post-thrombotic type symptoms. We did about 12 hours of echos, and at that point, his thrombus burden was basically resolved. TPA does have its possible complications, including bleeding, but it happens in a minimal subset of patients, and we're actually finding out you can reduce the dose of TPA given and thus reduce that risk significantly. And here you have a patient, 52-year-old female with a previous IVC filter that wasn't removed and was basically stuck to the vena cava. And we did basically endovascular thrombectomy, and we crushed that stent and that filter and stented and basically plastered it into the wall, allowing it to form a lumen. And here there's the thrombus burden after suction thrombectomy. So she had a lot of thrombus in there. Now, what about pulmonary embolism? So pulmonary embolisms, we stratify them into massive, which are patients that are symptomatic, hypotensive, tachycardic, high O2 requirements that need pressors and have documented RV dysfunction or right ventricular dysfunction. We have submassive PEs where they are symptomatic, they're not requiring supportive therapies as the massive PE patients, but you do know that there is a RV dysfunction, and then you have kind of minor PEs. And RV dysfunction is a good marker for if these patients require treatment. You look at the size of the right ventricle and compare it to the left ventricle. If the ratio is greater than 0.9, there's an associated mortality with it, and it's an indication for treatment. So here you have that the submassive PEs are a significant portion of these patients. So you have to watch out. And here you have supporting data to show that RV dysfunction measured by RV-LV ratio greater than 0.9 has a significant increase in mortality, 6.6% versus 1.1. And here you have RV dysfunction greater than 1.5 has even higher mortality association. And here you have kind of another study documented adverse outcomes based on RV dysfunction. So standard therapy for PEs is anticoagulation, as we know, usually heparin drip. And there is the rationale for thrombolysis is to decrease the thrombus burden. There are some studies looking at systemic thrombosis, but it has a high association, even though there's a mortality benefit, it has a higher association with bleeding risk, including intracranial hemorrhage. So that's why we kind of move into the catheter-directed thrombolysis. And here are some of the major studies looking at catheter-directed thrombolysis. The amount of intracranial and major bleeds is significantly decreased, even though it still happens. We're still trying to figure out how much time, and we're trying to decrease the time that we need to give these patients TPA and the total dose to decrease these events of bleeding and have better outcomes. And here are more of these studies. I'm not going to bore you with that. So here you have a patient that came in with a massive PE. You can see it's a saddle embolus. The patient had 12 hours of echos therapy, which is basically a catheter that has ultrasound vibrations along with TPA injection, and the patients become asymptomatic quite rapidly. At this point, we're doing like a 6-hour protocol, and patients' symptoms are mostly completely gone at 6 hours. And here's a patient that had a significant PE with significant pulmonary pressure elevations. And with this patient, we use penumbra, which is basically just a big straw that you can suck the clot out with. And here, note the pulmonary artery pressures. They significantly decrease and normalize after you remove the clot, and the patient basically becomes asymptomatic. And that's it.
Our next speaker is maybe well known to many of you. Will Harris has been a vascular surgeon here in this town for a number of years. Most recently, in 2020, joined VIC, and he comes from the United States Air Force. He's been assigned to Keesler and Nellis and San Antonio Medical Center, and is now here working with us and helping take care of the patients in this region. Will?
Sorry about my delay. The Erlanger hasn't made themselves more efficient yet. So venous disease is something about which I've become passionate over the last several years, and it really does go beyond just DVT or varicose veins and whatnot. But I mean, there's so much pathology associated with with the venous system. It's something that initially we kind of pushed to the side. We didn't think about it. We focused on arterial systems, and varicose veins was just a way that patients would show up and they have veins that are unsightly, and that's what we did. But there's so much more to that, and we've become so much more passionate about venous pathology that I think it's really important to take a deep dive into it. So, I mean, I could go all day about venous insufficiency and lower extremity symptoms, but chronic venous insufficiency is incredibly important to recognize, and it still astounds me to this day how many primary physicians and referring physicians and not even non-referring physicians just don't recognize them or cast them aside and whatnot. So, sometimes patients present just for cosmetic concerns, large varicose veins, painful varicose veins, swelling, edema, fatigue, itching, things like that, cramping, worse at the end of the day. These are the chronic venous insufficiency problems that the patients present with. So the SEEP score, although it's kind of small to see, I was hoping for a bigger screen. The SEEP classification is how one actually classifies these. I can send anybody my PowerPoint later, or you can look it up online. It's CEAP is the classification for venous insufficiency, and the level of disease and the extent of disease, and that should sort of guide your therapy. So as in everything else, history and physical is tremendously important. So when you're looking at a patient and the patient presents, you should automatically classify their CEAP score. Be you a physician, nurse practitioner, or even an ultrasonographer, that should clue you in as to what level of attack you're going to do as far as a deep dive and what you should expect as far as the pathology goes. If you have a CEAP score, say 3 or less, they maybe have some painful, fatigued legs, some unsightly varicose veins. You wouldn't expect to see really significant complex iliac pathology or history of DVT or something like that. But if they come in with significant edema, swelling, things like that, ulceration, that's when you should really take your time and do a very deep dive into that patient. And that means a really complete ultrasound exam, not only lower extremity, but in the central venous system. So this lecture really focuses on the central venous system. But again, we classify things when we're looking at these patients into an acute phase, a subacute phase, and a chronic phase. And what I think of when we say an acute phase, we think of less than 2 weeks. Why is that? And back to Lucas's talk when we talk about DVT, this is where it's really, really important. If they have sudden onset of symptoms within the last 2 weeks, that's your time frame to get to the point where you may incorporate, say, a lytics into your therapy if they have a DVT, but the clot is fresh. It's fresh enough that you can go in and suck it out and clean it out pretty well. There are new devices that allow us to go after things in the subacute phase. And that's incredibly important too, because that can, even if they don't get to you until that 2 week to 3 month period, you can still make a difference in their thing. You also want to go in and take a look at their inciting events, what caused, if they had trauma, if they had an open surgery and they started developing swelling after that open surgery, if they have a history of a hypercoagulable disorder, if anybody in their family has a history of a hypercoagulable disorder, if they've had night sweats, fevers, chills, things like that may confer, say, some oncologic etiology. If they've had trauma, or if they've had previous venous procedures, that's important too. Sometimes a patient will show up to you and they say, "Doc, I've had this stent put in, I don't know where it is." And so that may clue you in. And then, how much is it bothering them? If they present to you and they say they have a lot of swelling, but they have no other symptoms, they don't have any pain or anything else, is that something you're going to want to go after and treat? Could it be a problem down the road? Those are all things to think about. So the acute pathway, classically, rat poison, which is warfarin, heparin, Lovenox pathologies. Now we've moved on to NOACs, which has revolutionized the way we treat these. Most DVTs, if an emergency room calls and say, "I have a DVT in the ER," I say, "Put them on a NOAC and we'll see them in the office tomorrow." You don't have to necessarily put them on a long-term heparin drip. Now, Chris got sidelined with that yesterday. He had one that presented with phlegmasia and trying to die, and so that kind of stuff still happens, and that becomes much more of an emergency. You can't have them show up at your office door, but it's something to think about. It certainly changes the treatment algorithm. The availability of not only Lovenox, but the novel oral anticoagulants, it really buys you time. It's not something that ties up a hospital bed, especially in this area of COVID and limited resources. It makes it much more of an elective procedure that you can go in and fix these patients. And then, Lucas talked about, the patients that we're going after and trying to treat in these. And iliofemoral DVTs are really the ones that seem to make a difference from a data standpoint. And while the data is still mixed, it seems like these patients do get better. Why do we treat these? That's the big question. Decreased risk of pulmonary embolism. They have less chronic lower extremity reflux after the treatment. They have a better quality of life, quicker return to function, and much fewer long-term sequelae. What I mean by long-term sequelae, it's kind of impressive. In patients with post-thrombotic syndrome, those patients left untreated with iliofemoral DVT, up to 15% of those will develop venous ulceration at some time in the next 5 years. 40% will develop venous claudication. 90% of patients will develop some form of venous insufficiency that's symptomatic. And post-thrombotic syndrome, which encompasses all of those, is about 50 to 80% of patients. So I think, the data is there, and that's why you should treat them. It's not life or limb, but it's a quality of life to a certain extent. So post-thrombotic syndrome, what is post-thrombotic syndrome? So valvular damage secondary to the chronic clot. Oftentimes, and you'll see images of this in a little bit, you'll get scarring within the vein itself, and that will cause chronic inflammation in the vein and will degrade the valves, and that's what will lead to significant venous insufficiency. Not only in the superficial venous system, but also in the deep venous system. You'll get chronic inflammation, chronic swelling, and then, like I said, in some patients you'll develop ulceration. The most significant post-thrombotic syndrome we see is in patients who have a combined obstructive pathology as well as reflux pathology. So how do we manage these patients? Compression, 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 compression. But that's only goes so far. You can't wear an Una boot for the rest of your life. Well, some people do, but that's not the right thing, and they're pretty disgusting after a while. Leg exercises, that's really important. I tell these people to walk, keep their muscles intact, lose as much weight as humanly possible. That contributes significantly. And then endovascular intervention, kind of like what Lucas was talking about. And we have several different modalities. Catheter-directed thrombolysis is one of the classic ones. That's probably the longest standing one, started in the 80s, where we started to put a catheter in, and you drip tissue plasminogen into the clot for upwards of 24, 48 hours to try and dissolve the clot. Problem is you have to put these patients in an ICU bed. You have the risk of thrombolytics, which is not insignificant. if you've been practicing vascular surgery long enough, you've seen a patient have a stroke while on thrombolytics, and that's not a fun day. And then the clot can continue to propagate despite the thrombolytics being in place, or recur, and you're not necessarily treating the causative pathology with the thrombolytics. Oftentimes it requires a trip back to the operating room, which ties up more time, more contrast, more radiation, things like that. And it keeps the patient in the hospital for 24, 48, 72 hours, however long it takes to fix everything. Nowadays, we have more and more thrombectomy devices. It's changed the game. So a multitude of thrombectomy devices, both catheter aspiration and mechanical thrombectomy. It's becoming increasingly used in the vascular space. You have a very low risk of propagation to the pulmonary system with these venous thrombectomy systems. As a matter of fact, the Society for Vascular Surgery have guidelines as far as how we treat these patients, and most of them say you don't have to put an IVC filter up before we do these treatments. Now you can, it's not doing any harm, but they haven't demonstrated any significant benefit to that. And you can do the definitive procedure in the span of about an hour and do it almost on an outpatient basis, or often on an outpatient basis, without having to tie up, the hospital bed for certain periods of time. So again, there are different types of thrombectomy devices. Is this laser working? Yeah. So this one up here is one that Lucas was alluding to earlier. This is a NARI device, the ClotTriever, and what this does is it puts a basket up into the inferior vena cava, and that you deploy that basket and then drag it in to the sheath right here, and so you pull out the clot that way. It's pretty simple. I wish I had thought of it 20 years ago, but it's very efficacious, and you can use it in clots upwards of 3 months old. You'll get a fair amount of chronic clot out of a system, which is pretty impressive. This is a penumbra catheter, which Lucas also alluded to. This is the suction pump, and you put that catheter up into the clot. The nice thing is it has angles, so you can get it around different areas, especially used in stents that have thrombosed or whatnot. This is an older technology, but it's still a very good technology. This is an angiojet. This actually has a catheter that is 8 French, and it creates a venturi effect within the vessel and squirts out fluid to try and break up the vessel and then subsequently suck it out. One thing that it also does is you can power inject TPA into the clot too and let it percolate to further break it up. This is a very simple device made by Philips. It's just a suction catheter, fairly similar to this, but it works fairly well for these sort of things. Aspirex is a device that's only recently been introduced to the United States. It was used in Europe for several years. Similar to angiojet, except it just has mostly suction and doesn't have a power pulse type function, but it's a very simple, efficacious device. And then, this is the JEDI catheter, which is a catheter that has a power jet of fluid inside to try and break up the clot as well. So a whole host of new technologies, but we see a lot of DVT, and it's under-recognized, and it's really important to go after these. Excuse my play on words, acute, but I think DVCs are really neat, and they're very satisfying to treat when they're treated appropriately. This is a patient who presented to the office with a DVT. We sent him home with a novel oral anticoagulant and scheduled him to be performed in the office a few days later. Interestingly enough, and not picked up on his original ultrasound, he had a duplicated IVC, which you actually see in upwards of 2% to 3% of patients. So you have an inferior vena cava running on both sides of the aorta, and they merge about the level of T1, T2. I'm sorry, not that high. They merge about the level of T11 and T12. And so he had a chronic right DVT. Interestingly enough, had a inferior vena cava filter placed in that right-sided iliac or inferior vena cava several years ago that wasn't doing any good. We did the venogram on him, and this clot was both acute and chronic. We performed thrombectomy with the Aspirex and then reconstructed his system and crushed that stent. I don't know how much you can see that, but the inferior vena cava, we crushed the inferior vena cava there and put the stent in. So the inferior vena cava filter is sitting right there, and the stent is excluding that. I think Lucas did a case, shows a case that was very similar to that just a few minutes ago. But what happens if you let that DVT percolate and you've got a chronic situation? So this is what happens is you get an occluded inferior vena cava and you have a patient present with horrible long-term swelling symptoms. This was a 67-year-old gentleman who went on a car trip, a 9-hour car trip, and got out only once to refuel his car. He's a smart gentleman. He's actually an attorney, and had significant cramping to bilateral lower extremities afterwards, to the point where he had tickets to the Masters and he couldn't walk around the Masters. That would be tragic for me. That would be awful. So after the Masters was over, he went to his primary care doc, who correctly diagnosed him with a DVT, but just put him on Xarelto. Didn't refer him for any thrombectomy or anything else. 9 months later, he has persistent swelling, cramping, pain, finally presents to a vascular provider. And this is what he has. So this is a pretty spectacular picture of what happens if an iliofemoral DVT goes left unchecked. These blood vessels up here going up around the side are not supposed to be there. Should be one contiguous amount of flow into the inferior vena cava. These are all collateral networks that have developed because the inferior vena cava and iliac veins, common iliac veins, are chronically occluded. So we're able to cross it and then reconstructed him. And what's fascinating when you do something like this is what happened to all the collaterals. It's path of least resistance. It's a venous system. It's not hard, it's plumbing. So this fairly spectacular result in this situation. So, you know, there are other reasons to look deep. When you're seeing a complex venous patient and you've got this venous pathology, if they've had, say, a lower extremity venous intervention before, you want to think to yourself, why is the patient not better? That's a situation where you do want to interrogate the deep system, be it either with a CT scan or ultrasound, iliac venous ultrasound. And so this is a lady who's actually a housekeeper, and she stands on her feet for days and days, and she's had superficial vein treatments bilaterally, but she has horrible cramping, horrible swelling to bilateral lower extremities, worse at the end of the day. And sure enough, her iliac vein diameters, I don't know if you can read that, but it's 5 on the right and 5 on the left. And the normal size for her down in the external iliac system is around 10 to 12. So it's almost half of what you expect. And I think somebody here has a lecture on the iliac venous ultrasounds later, but I think they've revolutionized the way we look at these patients and heightened our index of suspicion. So again, she had persistent symptoms after superficial vein treatment. Patients who present with pelvic congestion syndrome, we'll talk about that more in depth tomorrow, but pelvic heaviness, pain with intercourse, heavy menstrual periods, those are all signs and symptoms of pelvic congestion syndrome. You should always look towards the central venous. You should think about the central venous system when you're evaluating these patients. And they may have GYN pathology as well, but I think it's important to at least think about it. And oftentimes in the GYN community, it's not thought about. Upper thigh pelvic heaviness can be symptoms of the chronic venous compression up top and persistent non-healing wounds despite adequate therapy. So this was a gentleman who was a special warfare operator when I was in the Air Force, who he had deployed like 20 times. Special forces, he couldn't tell me half the places he went to. But he developed a DVT while downrange. I think he was in Iraq or something like that. And he was listed as non-deployable now because you can't go downrange on a novel oral anticoagulant, because if you get shot, they can't stop your bleeding. And so he was stuck. All he could do was train other people to go, and he was miserable. And these people are wired differently. They're crazy. But his hypercoagulable workup was negative, but nobody had ever gone and looked at his deep venous system. And he'd had 2 recurrent DVTs and I think 1 pulmonary embolism. persistent swelling, especially the left lower extremity. So we performed a venogram with intravascular ultrasound, and he had a high-grade stenosis, and this is back before we had some of the newer stents, but we angioplasted and stented him with a fairly large stent, and now he is off his anticoagulation back to deployable status. Can you play those videos? These are the videos of his intravascular ultrasound, and this is a good segue into my next lecture. Play the one on the left first. Oh, really? Oh, there we go. Cool. So this is pre-treatment. You can see how compressed the iliac vein is. Let me play that again. So this is the iliac vein. You can see this is the artery running on top of it, and that's how compressed the vein became. And then this is after we stented him with the stent. And we'll go over this video again in just a minute because I think it's really important to see how the vein opposes to the wall, and you can see that with the intravascular ultrasound. So anyway, that's a really good example of why we look deep for these patients. So it's an outpatient procedure. Iliac venous stenting is an outpatient procedure performed usually under monitored conscious analgesia. In upwards of 82% of these patients, they have complete relief of their symptoms after this sort of thing. Complete ulcer healing in upwards of 76% of these patients. And they have a tremendous relief of swelling just with treatment of the deep venous system. So anyway, let me go to my next presentation, which we talk more about intravascular ultrasound and why we use it in the vein system. So you can't treat venous disease without IVUS. IVUS is essential to treating venous disease. This is a really great picture, and this is the iliac artery, and this is the catheter in the middle of the vein, and this sliver is the vein. So what is IVUS? It's a miniaturized catheter that's placed on top of a probe that goes inside the artery. We have them in different sizes. We have them anywhere from 4 French to 8 French. We use them for different pathologies, but it allows visualization inside the blood vessels for a better idea of the wall makeup of the artery as well as the pathology within the artery. Of course, the first person to come up with an idea of using a minimally invasive stuck one up a rectum. So they shrunk one and put a catheter in the 50s, believe it or not, into a rectum to identify neoplasms in the colon. But IVUS itself, intravascular ultrasound, parallels advancements in vascular surgery. So the first endovascular aortic stent graft was placed in 1991 by Perotti, and catheters started to come on the market for intravascular ultrasound not too long after that to treat advanced arterial pathology, especially in the aortic systems. I think the first thoracic stent graft was placed around that year as well as 91. And so they started to use it more and more for that type of pathology. We use it tremendously in treating complex aortic dissection work, aortic aneurysm work, things like that. And so they were large bore catheters that you would put on, but they've miniaturized them over the years. And now they're kind of a staple in our practice. By the late 1980s, these catheters were available. There are 2 types of catheters commercially available on the market right now. This is kind of above my head. One is mechanically rotating, one is electronically switched multi-element array system. Both work better The mechanically rotating one probably gives better better clarity, but the electronically switched multi-mode element array system has many benefits to it. It's much more user-friendly and whatnot. And what we do is we actually look at the arterial wall, the shading of the arterial wall, to determine what's going on within the vessel. And then some of the vessels actually have transducers where you can see the flow as well. So this is an aortic dissection. I think this is just this is a true lumen. The TL is the true lumen, which is compressed in the false lumen. So like I said, the first catheters were fairly large, and we used them within aortic pathology. But why do we use IVUS in veins? And this is a horrible slide for me because I hated histology, but I think it's really important in this case. The tunica media in a vein goes from here to here. The tunica media in an artery goes from here to here. So what does that mean? An artery isn't compressible, is not very compressible, whereas a vein is extremely compressible. So here's IVUS in a peripheral artery. You see all the pathology, the thick walls, and whatnot. You don't see that in a vein. And when an artery crosses over a vein, which we see in iliac venous compression, it flattens out. And so when we do vascular surgery, we use conventional angiography. So if I looked at this left iliac venous system, it looks wide open. But it's actually, in reality, pancaked out, where you can hardly see it. So if you look at the beginning of this video, catheter's in there and see the compression. The vein itself is almost occlusive of the the catheter itself is almost occlusive within the vein. Play it one more time. So it gives you a 3D representation of a 2D image and a real-time accurate. So why else is it really important? Number one, it gives us the ability to give an accurate measurement of the actual compression. So this is the representation, this blue line is the representation of normal vein diameter in the same patient, and this sliver right here is the pathology. That's the representation of the pathology. These are pre-marked. So this is the normal one that I measured earlier. This is the actual DVT. As you can see here, the catheter is almost completely occlusive in this area. And this is the right common iliac artery crossing over that left common iliac vein. And so not only can it give us an accurate measurement of the amount of stenosis, but it can also give us diameter measurements, which allow for more accurate sizing of stents. Because the last thing we want are stents to go floating up into the pulmonary system. You lose points for that. And so also the other thing is intravascular ultrasound can tell you where normal vessel diameter starts and ends, because you always want to treat from normal to normal with the pathology in between. Does that make sense? So it determines healthy landing zones, identifies anatomy that's otherwise difficult to see. It identifies pathology that's not otherwise visualized. So this is actually inside a vein. This is a chronic DVT right here. You can see the increased shadowing that you guys will see on extravascular ultrasound, but that may change my treatment algorithm. I may just angioplasty and stent that as opposed to do a thrombectomy on it, especially given the history on it. It's had enough time to become organized. But it also gives the idea of vessel sizing and, like I said, guiding therapy decisions. So pre and post treatment, this is the video I showed you earlier. That's within the stent. That's the catheter in the stent. And you can see there's fairly good wall apposition of the stent. There it goes. Oops. And this is pre. So you can see the catheter is almost occlusive in that region. So angiography, this is a completion angiography after we reconstructed the images you saw previously. As you can see, all the splayed out portions are gone, and it just allows us to have a better, more accurate reconstruction of the vessel walls. So, are there any questions in regards to either talks? Yes, back there. Yeah. Mm-hmm. Yeah. The collaterals. Yeah. So they won't embolize. Are you saying the collaterals? Yeah. A lot of them will clot off. The collaterals will clot off because again, it's a measure of path of least resistance. They will certainly, the wind will be taken out of their sails, is what I like to tell patients. Their flow will be minimal. I mean, those veins oftentimes existed there before. It's just they were very minute and small, and they became engorged because it was finding another path around that pathology. You know, the idea of putting patients on an anticoagulation after a DVT does not exactly have a thrombolytic type efficacy. What it does is it minimizes the additional clot burden. So he probably had a fairly decent sized clot to start with. Now sometimes they do recannulate. You know, the body will go back to your streptokinase, your hemokinases, and things like that, and break down that clot. But oftentimes there's such a high level of burden of clot that it's unable to do that. And so you want to definitely, the anticoagulation is important for the blood to find a path of least resistance, and it probably does help with the collateral, driving a collateral circulation to a certain extent. Oftentimes with patients with superficial DVTs, we will, with lower extremity DVTs, we'll put them in anticoagulation, elevate them, and it will decrease the thrombus burden to an extent where it decreases their swelling. Does that answer your question? Yeah.
I'm going to have both docs go up to the stage and see if there's any other questions. I think there's one over here.
Yeah.
Because it seems like even though the technology and the benefits have been known for 30 years, clinicians weren't really wanting to put their patients through. So I'm wondering, when do you actually go to catheter-directed thrombolysis for femoral, or is it only if you have iliac or IVC involvement? When do you actually do the catheter-directed thrombolysis for DVT?
So yeah, I mean that's, Lucas, you want to hit that?
I changed completely now to mechanical thrombolysis. It's just a 2-hour procedure. You remove all the clot. The patient's not exposed to TPA. So all the risks, in my opinion, are removed from the equation, and the benefits are still there.
Penetration that you see in the Chattanooga area, how many patients that have DVT actually?
How many are treated?
Yes.
A fair number are not. And so the question is what patients are we treating? And so femoral, I think, you have to evaluate the patient first. The data is better for long-term for the patient's sort of common femoral up. So if they have a significant thrombus burden within the common femoral artery, that's usually my go, no-go decision. Have I done it on patients with superficial femoral clot and seen an improvement who come in with significant swelling in the lower extremities? Absolutely. The problem is that's usually an 8 millimeter vessel compared to a common femoral can be 15, 16 millimeters in diameter, and then the iliacs can be the same or even larger. And so the long-term benefit of a superficial femoral thrombectomy is not necessarily, it's not as good as in a larger vessel. The other thing is you have other vessels flowing into the common femoral system to help drive and improve flow in that area. So you have the profunda vein coming out of the lateral thigh, you have the superficial venous system, if it's still open, the saphenofemoral junction driving flow into there, so that helps too. Whereas in the superficial femoral vein, you only have sort of one source. But I think it is underappreciated, and I think it's under-recognized that we have this technology and the ability to do it. And there are a lot of people running around who develop these DVTs and are just put on, blood thinners. It's the easy button, unfortunately.
Yeah.
But at least having the discussion with the patient, I think, is incredibly important.
Yeah. Things have changed. I'll just interrupt you just real quick because there's other questions. But just to give a little historical perspective on your question, when I was a young doctor 20-some years ago, all DVTs came into the hospital. They came into the ER. They got put on heparin because that's all we had, and then converted onto Coumadin. But they were generally held in the hospital, and anybody that was kind of bad, the vascular surgeons tended to see. because we had to decide whether we're going to operate on that patient or whether they're just going to stay on anticoagulation. Well, that paradigm's completely changed now because we have NOACs and injectable heparin, and patients hit the ER, they get put on a NOAC, and they're sent back to the primary care doctors who are never really trained on how to think about, who needs to get operated upon. So, I think there's a lot of patients that are out there now that if they have very severe symptoms, swelling, pain, heaviness, they probably need to be referred to a center that does the interventional therapy to decide if we even need to operate on that person or not. But there is a window. Acute DVT is 2 weeks. And so hit the ER, NOAC is fine, but if they're bad, get them to a center that does, some of this therapy.
Yeah, I think Chris is right. Around, when I was a fellow, probably 80 or 90% of DVTs you just treated with anticoagulation. Now I think the paradigm should shift. Is it shifting? Yes. Is it slow? Yes.
So this is just a question for myself, from an older vascular surgeon, not old, older, to younger vascular surgeons. I mean, what's all the interest in the venous world? Why is that? Because we start off, cutting our teeth on arterial, carotids, AAAs, bypasses, things like that. That's what vascular surgery traditionally has been. What's the interest in the venous world now?
It's pretty impressive when you fix somebody's complex venous pathology and they had swelling and cramping and pain and they couldn't stand at the end of the day, and they had to go put their legs down. They're like, and now they're 100% better. That's a pretty gratifying feeling for especially those complex, deep venous patients and things like that. And so, I think that's why I enjoy it. And you have to make things up as you go along too.
Yeah, it's more interesting, to be honest. There's in patients that have complete occlusion of their IVC, there's association with congestive heart failure. So there's a lot of things that aren't known, from the potential benefits, from a pure technique wise, what works, what doesn't, when does it work, when does it don't. So there's still a lot of questions to be answered. So in that point, I think it's more interesting than arterial.
And then again, from the older vascular surgeon perspective, we just didn't have the technology you guys have now. And we didn't have stents that really worked well. We did not have intravascular ultrasound. We had, we couldn't really fix a lot of these problems, so we didn't really look for a lot of these problems. But now that, I think one of our techs pointed out that the venous space is larger than the coronary space, right? It's actually it's actually the largest one of the pathologies that we all face as a country. And we now have tools to actually fix some of these things.
Yeah, but just a cautionary tale, but we should be really good stewards of it, because there's a lot of interventions going on at the moment, that at some point the pendulum is going to come back, and we just have to be really careful that we're looking at outcomes and risk and benefits, because I think in some circles the benefits are overstated and the risks are understated. So
yeah, no, I absolutely agree. There's a term, endo-enthusiasm, and to fix things from the endovascular space, it's something we've always kind of had to fight and prove. So one question, from the technologist side of things, we place stents like this, and now they're responsible for looking at these stents, and Will, you showed a stent that was coapted nicely on the bottom, but anteriorly it was still free floating. I'm curious from the senior techs, kind of the thoughts on like shelving, stent shelving. Is that something that's a concern? You see a lot of thrombus that forms. We're doing all these procedures. What are the things that are most concerning? And Sarah, I'm going to ask you to just at least comment about that from your experience. For the stent pathology, what things do you worry about? Stent shelving, free floating, what's worrisome?
Right. I think all of those would be concerning from a sonographer's perspective. Not only would we be thinking about that stent thrombosing again, which would be obviously hugely problematic, but you still have the possibilities, and we were kind of going through this a little bit as well, where that stent might not even be covering a narrowing, so the patient still could be coming back with the same symptoms. So as a sonographer, like we not only look at the patency, but we also want to confirm that that stent is underneath the artery and kind of, sometimes it kind of pokes into the IVC. So it's pretty important to identify. And then along with that, any type of migration of the stent. I mean, that would be hugely concerning.
One last question, and I'll just throw it out there, because we are hitting that lunchtime, which I'm sure everybody's kind of getting ready for, is anticoagulation for these venous stents. I tend to be very aggressive with anticoagulation. I'm usually putting people on full anticoagulation for at least 6 months after these stents. I'm curious of your centers. Lucas, I'm curious about what you do, and Will, what is your paradigm?
I oftentimes will do just Plavix and aspirin for 6 months, and then aspirin daily for the rest of my life, unless they have a history of, DVT, something like that.
Sure. And there's two kind of categories. There's one who's post-thrombotic, and the other person who's
Correct.
just...
Correct. And then somebody who has really, really complex reconstruction, I'll put them on Lovenox for 2 to 3 weeks. And there's a recent paper suggesting that has improved long-term outcomes, and then switch them over to a NOAC after that.
Lucas?
So, my subset of the patients that get to me are patients that have chronic occlusions, usually longer segments. So they go on lifelong anticoagulation.
Yeah, we would do 6 months of a DOAC, unless it's from a chronic obstruction, then it's possibly be a lifelong.
So you see that there's a lot of variation, and we had 5 different people saying 5 different things. And that's because we don't know yet. I mean, this is so new, we don't know what the long-term outcomes are. It seems to be that the people who do the most of these, the big centers, are tending to be very aggressive with anticoagulation, and I think that seems to be the right answer. Most of these people are relatively healthy, and so they tend to not have the bleeding complications as some of the really older, sicker patients do.